Welcome to the Honest Health Podcast with your host, Jeffrey Burke. Honest Health brings you the brightest minds in the natural products industry, as well as athletes and entertainers. Jeff will keep you entertained and informed while educating on how to be successful on your healthy journeys. Now, here's your host, Jeffrey Burke.
Hello and welcome back to the Honest Health Podcast. My name is Jeffrey Burke, and I thank you for tuning in. This is my newer platform, the one that brings you the most up-to-date, groundbreaking information from some of the best minds within the natural products industry, as well as voices from outside the industry. Because let's face it, in my mind, the way my mind works is everybody has something great to share. I feel that information and tips and beneficial ideas can come from everywhere and every direction. If you like what I'm doing, please consider giving me a like or a share or subscribe, or better yet, do all three. And I would appreciate it because I want to get visibility for my guests. I want my guests, their interviews to be out there and to be available to everyone. Don't forget to go to my YouTube channel and click the subscribe button as well. Today, I'm going to be talking with Stephen Barrett. I don't know if you had a chance to see my interview with him on his podcast, but it was awesome. And I was so excited. And I thought he was such a wealth of information. We really needed to have him on here. And I think you're really going to enjoy today's topic. So sit back, enjoy. And remember, this is going to be one you're going to want to pass on because the information is going to be priceless. Help me welcome my guest. Hey, Stephen.
Hey, how are you doing, Jeffrey? Honored to be here.
My pleasure. I'm so glad to have you here. I had such a wonderful time on your podcast, and you are an amazing icon, and you are so good at what you do, and your information is, it's just really, really important, especially in today's world. And I know today we're going to be talking about diabetes and things associated or that we're plagued with or could go in that direction with diabetes. And diabetes is one of those things right now. I call it like a big gang or a big club, and they're taking new members every single day. And it seems like everybody's joining that club for one reason or another, whether it's genetics or lifestyle choices or things along the way. But I'd like to talk about that today because I know this is an area that you have amazing amount of expertise in. So wherever you'd like to start, I'm along for the ride.
Well, I think the biggest thing that I would like to share today is the knowledge that we are able to reverse the majority of symptoms of diabetic peripheral neuropathy.
It's big.
Via a surgical decompression technique. And what's really interesting about what I'm going to share today, although it's new, it really started in the 1980s. So you know how big of a boat mainstream medicine is and how long it takes to turn that boat, even in light of very demonstrative scientific evidence. And we have that. So I want to talk about specifically diabetic peripheral neuropathy because about half of all neuropathy is due to diabetes. And as you mentioned, diabetes is getting more prevalent, not less prevalent as we go on. We're one of the sickest societies on the planet and continue to do so. And I think that this topic will be able to help a lot of people because they won't hear this from their routine endocrinologist or their routine neurologist. And in fact, I've been working very heavily in this space since 2001. And while we are gaining more and more traction as far as awareness is concerned, it still is relatively unknown. So that's what I'd like to focus in on because I think that's how we can help the most people that are suffering from diabetic peripheral neuropathy.
Well, it's interesting to me, and I know you just alluded to it, that it takes so long for something that has so many benefits to become mainstream and accepted, but there's stupid stuff that gets accepted an hour after they figure something out. And I think to myself sometimes, there's no studies, there's no research on what you're talking about. And here we have a situation that has so much information behind it. But this has kind of been the way it's been in this industry. I'm well into my fourth decade, and I've seen so many things that have come our way. And, people will believe anything. And then if you give them good information, they want you to prove every single thing. And even with the science, it's slow moving.
Right. So can I start with the story of how I discovered this? And then, because I think that'll give a lot of context for the person who's looking at this. So I crossed paths with a gentleman named Lee Dellon, who is a retired professor of plastic and neurosurgery at Johns Hopkins in 2000 or 2001. And we hit it off on the telephone. And a week later, I ended up in his office up in Baltimore. And I saw these people that were reversed. Their symptoms of diabetic peripheral neuropathy were reversed by decompression, surgical nerve decompression. So like a carpal tunnel, when someone gets a carpal tunnel in their hand, the treatment usually is it's a surgical procedure where they open the tight space around the nerve, and the folks then get relief of their pain. And so Dr. Dellon, who then became my mentor, frustrated the hell out of me that week because I saw all these patients in the back of my mind that I had told them, sorry, there's nothing that can be done for diabetic peripheral neuropathy except maybe give you a medication like Neurontin or gabapentin, which is Neurontin, or Lyrica, pregabalin, one of those drugs to maybe mask the symptoms a little bit. But there's nothing that you can do to reverse it. And then I saw these patients in his office, living examples of people that had decompressions on one side and they were coming back to get their other side done, and they had complete sensation. And so that created a few sleepless nights for me because I had all these people in my mind that I had told them, sorry, there's nothing we can do for you. You got to live with it, and that type of thing. And peripheral neuropathy can be a devastating condition for a patient. It in some folks, it leads to suicide. It's so bad. So it's one of those things where I'm super frustrated still today that we haven't been able to inculcate this to the general mainstream, but we're making more and more progress on that. And over that period of time, there's been a tremendous amount of publishing that's gone on. So when I learned his story, which I want to share with you because I think it's a very compelling story. So when he was in the probably early to mid 80s, when he was at his hand clinic, patients with diabetic peripheral neuropathy would be referred to him and for their pain. And they would come back after he would do their their carpal tunnel decompression. And they would say, you know what? My pain is gone, but now I have sensation in these two fingers and half of this one. And I never had sensation in that. And he's like, wait, this can't be, because we're taught in medical school, and they're still teaching it today in medical school. Like I just said, once you have it, that's it. There's nothing more that you can do for it. So in the early to mid 1980s, he discovered, when patients were referred to him by neurology for chronic carpal tunnel syndrome, that he was able to reestablish sensation after that, in addition to relieving their pain. And this was something that was being taught in medical schools at that time, that once you have diabetic peripheral neuropathy, that's it. There's nothing that can be done. And now he's got these patients that are coming back saying, gosh, I've got feeling in these two fingers and half of this one. And he's like, well, this isn't supposed to be. So then he decompressed their ulnar nerve at the elbow and then got sensation into the little finger. And then later on, they would come back and say, well, what about the top of my thumb? It's still numb. And then he found the nerve that went to that and decompressed that. And now all of a sudden, these folks that had complete numbness and burning and tingling in their hand had a normal sensation in their hand. Wow. So the next question that they asked was, well, what about my feet? Because my feet are worse than my hands. And interestingly, most diabetic peripheral neuropathy starts in the foot, and it's much worse in the foot than it is in the hand. So he said, well, I don't really know anything about peripheral neuropathy in the feet, because I'm a hand surgeon, plastic surgeon. So, but let me go back down to the lab and we'll figure it out. So he found the same nerves, analogous nerves in the lower extremity. And by decompressing those nerves, he was able to restore sensation and reduce or eliminate their pain in their lower extremities. And most of his patients would come back for their other extremity to be done. So this was pretty significant findings. So then he had to prove this in the lab. When you're a professor at Hopkins, in order to advance through the academic ranks, you have to do a lot of bench research as well. And so what happens in diabetic peripheral neuropathy is that the peripheral nerve gets about 50% bigger, swollen, than a non-diabetic nerve. So when that nerve goes through a tight tunnel, like the carpal tunnel in the hand, it is a superimposed nerve compression on the nerve itself. So this is a very important distinction that must be made, is that you're not treating diabetic peripheral neuropathy per se by a nerve decompression, but you're treating the superimposed nerve compression that exists in patients with diabetes. Now, for example, carpal tunnel in the general US population is about 1%. In the diabetic population, it's anywhere from 14 to 28%, and even more in some studies. So now that's orders of magnitude different in a patient with diabetes versus a patient without diabetes. So he then went into the lab, worked on rats, and he was able to make these rats diabetic by injecting them with an agent called streptozotocin. They would get blood sugars of about 400, very sick rats. And then half of his rats, he basically did preemptive decompressions of their tarsal tunnels. Yes, rats even have tarsal tunnels just like humans do. And so then he was able to look at their walking track patterns. And as they progressed, their paw spread would deteriorate. So they would lose their function in their feet. And so in the rats that he did the decompressions on, those rats didn't develop that. Okay, wow. So he was able to prevent the development of peripheral neuropathy symptoms in diabetic rats by decompressing their tarsal tunnel. And they said, well, that's great and everything, but those are rats. And so then he followed it up with a primate study, and then his rat study was followed up by a group in Turkey and a group at the Cleveland Clinic. And so it's been very well demonstrated in the laboratory that this is what happens. Now think about that. I mean, we're talking about a discovery that was made in the mid-1980s. And when you have diabetic peripheral neuropathy, what's one of the things that you're subjected to? Well, loss of protective sensation. So if you lose your protective sensation, you can wear a hole in your foot and not even feel it. And that's what happens to a lot of diabetics. In fact, it's a very high incidence. 40 to 50% can develop an ulceration. And then you also have the associated recurrence, which can, depending on the source that you look at, can be up to about 40% of people. Once they get their ulcer healed, within 1 year, 40% of them will have another ulcer. Mm-hmm. Now, this treatment's very expensive, and it's very difficult, not only for the patient, but for the patient's family. They have to go to wound care centers. They have to do a lot of work to get these wounds healed, off weight bearing, different types of, wound biologics, all kinds of things, very, very expensive. And then to think about the fact that once you get this ulcer healed, well, now I got a 40% chance of getting another one within a year, and it's 100% at 5 years. So it's not like you've done great work at the wound care center. And I'm not trying to dog those folks at all, because the work that they do is spectacular, but they're not, by treating a wound that way, you're not getting to the core or the true etiology of it. And so whenever you can treat the core, the symptoms go away by themselves. So, and it's been demonstrated now that in a patient with peripheral nerve decompression for diabetic neuropathy, that recurrence rate is down to less than 5% per year. So that's a significant thing. Now, tremendous cost savings with that. I mean, think about the amount of money that our healthcare system pays to have extensive wound care, and then, there's a subset of those people with chronic wounds that unfortunately will get osteomyelitis, severe infections, and then they lose their leg or their foot to an amputation. And once that happens, then your mortality rate goes way up, because, that's, if you look at some of the studies, it's up there with things like different types of cancer as far as severity, as far as life expectancy is concerned. So you're doing a lot of work for these patients with this type of surgery, and you're not only preventing them from going to the wound care center, but a lot of them you're preventing from dying.
Wow. I think to myself, as you're saying this, it would have to be a patient that was also committed to keeping blood sugar levels in the normal range. It would have to also be someone that, would not be arguing with the ramifications of still being a diabetic. They still have to do the things that they have to do,
Right.
hydrate and exercise and watch their weight and all that
Right.
kind of stuff. Because although this will remedy that end result situation, it isn't a magic wand. You still have to do your due diligence along the way, I would presume.
Well, that's absolutely correct. And you make a very good point. Now, one of the considerations is they say, well, it's not safe to operate on patients with diabetes. And the answer is that's totally erroneous. And that's been proven with large numbers of patients. But we still want them controlled from an A1C standpoint as much as we possibly can. And there are some patients that their A1C is too high and they are not a candidate for the surgery, or their vascularity is not beneficial enough. And so the last thing you want to do is make someone worse. So I'm not saying that this is, for every patient with diabetic neuropathy. It's maybe not indicated in a subset of those people that don't have adequate vascular perfusion, or their A1C is too high. They're going to, but generally it's very safe to operate with this type of a procedure on them, because what happens, and this is the interesting thing, is that not only does it relieve the pressure on the nerve and take those symptoms away, but it increases the vascularity of that patient. So now they have more blood flow to heal and to keep themselves, well as about 70% of them will have a restoration of protective sensation. So when they get a little pebble in their shoe, they know it right away versus the one that doesn't. So those are very powerful things. But yeah, it's a method to take care of part of the whole thing. But these people still need to really think about, it's not just a magic wand. You still need to take care of yourself. And then by doing this, we're improving their balance, okay, because proprioception is increased. So now they're less likely to fall. So that takes a big factor out of it. And so then they can start to maybe walk more, which then feeds back the exercise loop. These things that will overall help the overall status of their disease.
This is incredible. I love it because the dominoes just keep falling. All the benefits in so many different areas that you get to gain by this whole procedure. Is it today? Is it well accepted today? Are we still fighting battles?
Oh, I think there's some areas that people are still fighting battles. But yeah, it's more and more accepted. And the problem is that there's only about 200 surgeons out there in the United States that are really educated on this to do it. And, so if someone's interested, I recommend that they go to the Association of Extremity Nerve Surgeons website, because they can find people there that are adept at this type of surgery and understand it. But it's real interesting. When I started doing this, I remember going back to my hospital in 2001 after spending a fair amount of time with Dr. Dellin. And I had a great relationship with him. It was a small hospital, and I'd been working there for, at that time, probably a good 10 plus years. And they said, yeah, well, this sounds a little bit hokey, but if you say it's real, we believe you. And so then the chief of the hospital, who was also one of the anesthesiologists, came to me after about 6 months, and he said, I kind of thought this was all BS when you came in here, but he said, I'm seeing all these people that are coming back for their second leg to be done. And he said, that means more to me than any journal article, because people will not come back for another surgery unless they've had a great benefit. And in fact, we tracked patients for 1 or 2 years in the early 2000s, and we saw that it was about 84% of them that would come back to have the other leg done. So that kind of proved it out. But now the literature, there's some very large studies that have been done. We're talking about thousands of patients now, highly respected peer-reviewed articles, university-based stuff. So it's no longer an enigma. It may be from the standpoint that people aren't aware of things. So if you and I don't know about anything and we hear something that sounds a little bit maybe different than what our paradigm is, then it's arbitrarily, that can't be. That's too good to be true, or whatever. But you get to a point when you start to see it a little bit, it's like, yeah, maybe there is something to this. I need to look into it. So that's kind of where it is. But yeah, it's being more and more accepted. And now the interesting thing is that some of the university-based studies now are showing what happens after peripheral nerve decompression in the patient with diabetic peripheral neuropathy. And one of the things is that on the plantar aspect of this foot, on the plantar aspect of the foot, there is this mechanism called pressure-induced vasodilation. So when there is pressure on the foot, and this just goes to show you how miraculous our bodies are. I mean, the physiology is, we think we know everything. We don't know everything. Trust me. There's a lot that we don't know.
Truth.
But what we're finding out now is that if you lose sensation, the nerves are no longer able to create this pressure-induced vasodilation. So what happens when you put pressure down on the sole of your foot when you have normal sensation is that it detects areas of high pressure and it shunts more blood to that area because, like when you fall asleep with your head on your arm, your fingers start to tingle, and that's because you're getting an ischemia, a lack of blood flow to that area. And usually the first thing that affects is a tingling of the nerve. Well, imagine it from a delivery of all of the necessary ingredients to maintain normal cellular function, oxygen, all of the other things. And now it's getting shut off and it's not able to shunt it and create more of a flow in that area. Well, now it's been demonstrated that this surgery actually reestablishes that, which is a tremendous thing. And that's probably why it drops the recurrence rate of reulceration down to under 5%.
As I'm listening to this, I'm thinking about all the people that I know that have had this, some of them are gone now that had this problem for so many years and were told that it was only things like, gabapentin and things like that, or even opioids they gave them to control the pain and, how it just completely took away the quality of their life. And I think about the idea of the decompression. I have a friend that was in such severe back problem, and they found out that he had a disc that was bulging and it was causing a compression in that area. And they did the surgery. There was a microsurgery. They went in and shaved and kind of pushed things back in and stuff. And an hour after surgery, he got up and bent over and touched his feet, and there was no pain. It was very fast. So my question about this is there a severe amount or a lengthy amount of time for healing before you see a benefit? Or once it is the decompression is done, is it something you notice quickly?
That's a fantastic question. And the answer is we have to dive in a little bit more here. So when you have a nerve compression, one of the first things that you will lose, well, I shouldn't say the first, but one of the things that you will lose is motor strength. All right. So for example, we are able to measure the motor strength, how much strength in the big toe when it's being pulled up. And we will see an increase in strength in the PACU minutes after the surgery is done.
Wow.
Now, the restoration of sensation to a protective level can take maybe up to 6 months, but the other findings, the pain is almost always better the next day. They'll say, in fact, when people started coming back after their decompressions, when I first started in 2001, I believe it was, the first thing that they would say almost invariably at the first post-op visit was, when can I get the other one done? Because the pain was gone.
Fantastic.
Now, so that's a very telling thing. Now, Dr. Dellon has an interesting thing that I think he actually has a little video on YouTube about it. But what he'll do is a lot of times in the recovery room, he will go and tickle the bottom of their foot, and they'll feel that right after they're waking up from the surgery. So he calls that the testicle, and it's a great term, but it's great from the standpoint that you're seeing these effects right away. Now, one of the things that we did was we brought neurology into the operating room, and this was probably around 2010, maybe. So we brought in a neurologist, and then we brought in a neuromonitoring team from Medtronic. And what they did was they did intraoperative EMGs. So they would get an EMG I would get down, I would create the surgical approach, get down to the nerve, and then they would do an EMG, and then I would take the tight bands, the constriction off of the nerve, and a few minutes after they had measured the baseline, we would measure the next, EMG, and we would see sometimes it would go from 0 milliamps to 6,000. I mean, it was almost instantaneous. So what that says is that by just simply getting blood flow back to the nerve, it can now function. And so that's almost a real-time experience. And these folks were blown away when they saw that, and because that's not what's traditionally trained, or what their traditional understanding is that, hey, it should take a long time, but nerve regeneration takes a long time, right? So the rule is it's about 1 millimeter a day, about 1 inch a month, that type of thing for true nerve regeneration to occur. But as far as a nerve that hasn't been cut or interrupted in some way, like in a trauma, you can get a very quick response just from getting the pressure off of that nerve, and then that increases the blood flow to it.
Do you find that the success rate is better in one or another, women or men, or is the results nerves or nerves or nerves?
Now, that's a great question, because in many neurological situations, there's always a preponderance of females to males. Okay, so if you look at like complex regional pain syndrome, some of these other things, it can be 3 to 4 to 1, female to male. So we don't know why that is. I mean, there's a lot of speculation that may be tied into what estrogen is doing and some of these very sophisticated things that are way above my pay grade. But what is interesting is that in general, you would think that the longer someone has a nerve compression, the more internal damage you would expect in that nerve. So it would take a longer period of time for some nerve regeneration to occur. And that is true. So you'll see patients that have maybe had symptoms for 25 or 30 years, and they're almost totally insensate. And they will oftentimes get a return of sensation, but maybe not back to the level that someone who has it treated earlier would. But that doesn't preclude them from being a candidate necessarily. And then, it's one of those things where we know that the longer the nerve is compressed, the more damage it is. So if they're having significant enough symptoms, it's better to get them in sooner rather than later. But nerves are pretty phenomenal because, they're very fickle. And they'll respond. Like I've had people that have had, a drop foot for 25, 30 years, and I'll tell them there's no way that we can get this, foot to function again, but they want to have the surgery because of the chronic pain that they're having. And lo and behold, they'll come back 4 or 5 weeks later, and all of a sudden they can move their foot like they couldn't before. Well, that doesn't fit the scheme that we have in our minds, but it just shows us that we don't really know that much sometimes.
I was at a rodeo a couple of weeks ago because I have horses and I announce a lot of rodeos for benefit events. And there was a guy that I saw there, and this just makes me kind of frustrated that people sometimes don't think about their health and well-being. So I was watching, he was pulling off his boot, and he said, "Man, my feet are so sore." And he put his sock off. He had a nail in his foot and did not know it.
Wow.
And I told him, I said, "Are you diabetic?" He goes, "I don't know. I've never had it checked." And I thought to myself, oh my. Yeah. So I called over the medics that were there, and they called over, and he went to the hospital. They removed it. His blood sugar was like 700. Yeah. A1C was closing in on 14. And so I have heard from him since then, and his diet has changed. They've got his blood sugar under balance. I mean, he's down to like 6.5 with his A1C, and the sugar's doing really well. And he thanked me, and I said, "Well, I'm just sorry nobody ever pointed this out to you," but it actually scared me to think that there was a nail in his foot and he couldn't feel it. And I wonder how many people are walking around with diabetes and don't even have a clue.
Oh, there's a tremendous amount. And then there's a lot of them walking around that are tremendously affected, and they don't know really where to go until they develop a wound, an ulceration, and then they end up in a wound care center and that type of thing. So the message I'm trying to get out is, hey, folks, if you have diabetic peripheral neuropathy, find someone who is doing this type of work, and that might just prevent a lot of problems for you, ulceration, amputation, and it will ultimately lead to a better quality of life.
Do you find that the surgeries are being done mostly in larger cities at larger hospitals? or is it being done in maybe private kind of clinics as well? Or is it just there a plethora of places?
I think there's across the U.S., there may be some small rural hospitals that people are at and that type of thing. Usually it's a little larger of an institution that are doing it. Quite frankly, I serve as the chairman of the board of trustees for the Association of Extremity Nerve Surgeons, and we're very frustrated with the fact that there's not more surgeons doing this, because we think it could really turn the table, not only from a individual patient standpoint, making that we know their lives are going to be much better, but from a healthcare cost standpoint, why is it that well, I know the answer of this, but why isn't that big medicine, like all of the other big things, wouldn't jump onto this? And maybe the truth of the matter is that there's not an economic driver. I mean, it's easier to keep somebody on an antidepressant the rest of their lives than to try to really get their depression turned around. So maybe there's some of that going on. I don't want to be putting my tinfoil hat on, my conspiracy hat, but I have a feeling that there's not a lot of motivation from industry. And if there was, they'd probably be beating the drums pretty hard for this.
Had I followed through and became a surgeon, which is what I wanted to do originally, and then I started on this side of the fence, and I've been on this side of the fence putting people back together for 4.5 decades, I would personally want to jump in and do this, because diabetes is not going away. The field of patients is growing every day. And the application of this amazing technology would be something that could change so many lives. No matter what I was doing, I'd want to move over and do this, because the masses need it.
Right. And there's something tremendously fulfilling about this.
Oh, yeah.
I mean, I've had patients. I did a TED talk on a patient that I had named Roger, and I didn't really realize how impactful this was, because as a surgeon, sometimes you're going along. It's like, okay, great. They've got more motor strength. They're not falling all the time, that type of thing. But you don't realize the full ramifications of what's going on from that patient's perspective. And this gentleman came back to me and he said, hey, he goes, I want to thank you for saving my life. And I said, I don't think I saved your life. I made your foot, not hurt and get a little better sensation. He goes, oh no. He goes, this was a guy mid-40s, an engineer, smart man. And he said, no, you don't understand. Pain was so bad. I had it all planned out. I had the gun. I had the note written. It was all in my briefcase, and, a guy with a couple of kids and a wife. And so you don't realize what you're able to do for these people until they come back and tell you. So yeah, no, if I could wave a wand, I would get 1,000 surgeons throughout the United States and just say, all right, hey, this is the only surgery you do, but just do it a lot and do it well. And what an impact that would have.
Oh my goodness, because this is such a huge area of debilitation to so many people that not only takes away their energy and their activity, but it takes away their zest and their vitality. And then it leads to so many other, crossover type situations, because if you have diabetes, there's a really good chance that it's going to lead into other cardiovascular problems, or you're going to be dealing with blood pressure or cardiovascular. I mean, there's going to be things, because they're connected, they domino into each other. And I'm just very, very excited about this. I mean, I've been waiting for us to do the show, but I've really been anticipating this, and I'm even more energized by just listening to you.
Well, hopefully we'll get the message out to some people, and they'll start, but it has been pretty grassroots. I mean, it's amazing, how many people will refer their friends and other family members in once they have it done. But it's just a matter of awareness. It's like, why can't we get that awareness level way up there?
It reminds me of something like, you go around the world and you see many children that have cleft palates.
Mm-hmm.
And many of them are in countries where there's no availability. There's no doctors there to do any of the surgeries there. Yet other parts of the world, they're being successfully done with absolutely no problem, with almost 100% success rate.
Right.
And sometimes our biggest problem is we don't know, or the information is not filtered to the area that we are at, or we don't know where to look, or we just have given up thinking that there is nothing that we can
Right.
do. So, I mean, keeping these messages alive is very important, and allowing people that there are things out there that can make a difference. And for anyone out there that is suffering, this is something that you should definitely look into and do your due diligence, do your homework, because you're going to be the benefiting party from this
Right.
if you find out a way to get it done.
Well, let me add one thing too, because a lot of
Please.
patients will say, what is the post-operative course? If I have this surgery, how long am I laid up? That type of thing. Well, we actually let you start walking that same day. We don't want you doing a lot, but usually by 4 or 5 weeks, the patient's back to regular day-to-day activity. And it's not a really invasive surgery. I mean, it's multiple decompressions, but it's not like you're cutting bone and, realigning it and putting screws and plates and those types of things. It's all soft tissue. So if you have a surgeon that knows what they're doing and does a lot of these, it's a pretty minimal post-operative course for the patient.
Is it laparoscopic?
No, it's not. It actually requires open incisions. Now, there has been an evolution where there has been some things that can now be done endoscopically, but generally for this, it's 3 or 4 incisions, usually 3.5, 4 inches. But they heal pretty darn well. And like I said before, you're increasing the vascular supply. So the nature of the surgery is beneficial as well.
And there's so many, and I know you mentioned this already, but there's so many diabetics that they just don't heal. And it has a lot to do with that blood flow. It has a lot to do with the parts of the body that they don't heal well on, knowing that those are problematic areas. And as a wonderful benefit of this, to be able to have that ability to be able to heal effectively again, I'm very excited about this.
Yeah,
If you can't tell.
Yeah. Well, and it's something that, people will say, when they operate on someone, if they're a true good-hearted surgeon, their payment is that they've made this life now a much better life. And when people come back and say, I need the other one done, and I need this done for my cousin and that type of thing, because my life is so much better. That's really it's a spiritual repayment. And, so there's a lot of tremendous gratitude with this surgery because people don't expect much.
I think that the other parts of this are also important. If you've been really bad to yourself over the years and you have not treated yourself in a healthy manner, and your choices have not been as good as they should have been, I think that it's something that you're going to have to make those adjustments, because we deserve to be healthier and we deserve to feel better. And, and there is no magic wand. I mean, you have to eat the right foods, and you have to have activity, and you have to hydrate your body, and you need to have rest, and you need to be able to manage your stress and decompress from your stress. And you have to get away from the negativity and work on the positivity. These are all things that we personally can control.
Exactly.
But they're also the things that people tend to not control and consider it more of a burden, but they should actually consider it more of a blessing.
Well, here's a consideration that goes right down that alley is a lot of people don't realize what the first symptom of diabetes is, and that's depression. And so if you're depressed and you're in pain, you're likely not going to be eating well, and you're likely not to be doing exercise. And so I'm not trying to say this surgery is the end all be all, but sometimes it can be the benefit enough that it changes a patient, gets them out of pain, gets them the ability to start doing other things so they can start taking care of these other core issues.
I see so many possibilities with this for so many people, and being able to bestow an amazing chance for a great change and quality of life.
Right.
And I think it's fantastic. And it eludes me too why more surgeons have not just jumped on this. I guess I'd maybe think differently, and you think that way too. It's like, come on aboard. There's plenty of room and we need you.
Right. Well, it's hard to get into the surgeon's mind, and they're highly trained individuals and critical thinkers. And this is something that they weren't trained. And so it takes a while for the tides to shift,
Well, even in my industry, it's taken forever. I come from a time, it's close to 50 years ago when I was starting in this industry. And I couldn't get the doctors to even want to talk to us in the same room because they had made their mind up. There was nothing to do with nutrition. It had nothing to do with this. Right. And what's funny today is now I get asked to speak at physician symposiums to teach doctors how to balance their own stress and well-being nutritionally. Right. So there's been quite a metamorphosis on that side as well.
Right. Well, think about this too. I mean, take a look at a lot of the physicians, and I don't mean this in a mean way or anything, but how's a physician who doesn't even take care of him or herself, how are they going to take care of other people? It'd be like going to the auto mechanic and that guy's car never runs because he never puts oil in it, or he never gets, so it's kind of like the smoking pulmonologist thing, it's like, maybe you shouldn't check him out, so.
Well, I want to thank you so much for this. 2 questions I have for you, and I never prepare my guests, so I'm going to kind of hit you blindside a little bit. The first one is, leave us with a thought of the day, something that you want people to remember that would make their life a little better.
Well, I think the thought of the day, and tying it into what we've just talked about, I would say that if you're diabetic and if you're having signs and symptoms of neuropathy, maybe check things out right away, because a lot of problems can be prevented and your life can definitely be made better.
I love that. Question number 2. Stephen, if you were to leave the planet today, what would you want people to remember you by?
That he really cared about his folks.
I love it. I knew you were going to go there. I just knew it. Thank you for that. And that's caring and, having those wonderful emotional ties to the people around you and wanting to lift people up. Right. Thank you for that. I love it. I hope you guys have enjoyed this today. This has been a wonderful, wonderful show, full of information. If you're diabetic, if you know diabetics, if you are familiar with people that have been dealing with this, make sure they hear this show. Make sure you pass on the link to them. And how will people get a hold of you? Let's say they want to reach out. Talk to you about, let them know how to find your show, and how would they reach out to you? Maybe they have questions.
Sure. Yeah. They can always reach us at thepodofinquiry.com, which I hosted you a couple weeks ago, and it was fantastic. And then I would suggest that they go to the Association of Extremity Nerve Surgeons webpage. It's AENS.us. And that has so much information on it. They can find a surgeon in their area. They can find the literature, a lot of stuff that I talked about just now with you. And I would think that would be the best resource for them.
I hope you guys enjoyed this today. I've been speaking with Stephen Barrett, and we've been talking about a lot of things in the diabetic and diabetes category. I hope you enjoyed this. Remember, if you like the show, go to my YouTube channel, click on the subscribe button. And remember, the whole idea of this show is to talk about all things good health and well-being from inside and out, and from inside and outside of the natural products industry. Stephen, I thank you so much for being here today. What an absolute pleasure. I've been excited about this all week.
Likewise. It's been an honor for me to share this with you.
Will you come back and see us again?
Anytime.
Wonderful. Be well, everybody. Do something great for yourself, and God bless.
Stay tuned for more information from the Honest Health Podcast with Jeffrey Burke. And make sure to check back often for interviews and conversations from the guests we all want to hear from. I'm John the Announcer. Thanks for listening.